Hello everyone. Today I'm going to talk about HIV prevention and particularly a new biomedical intervention called HIV pre-exposure prophylaxis. Over the next 10 minutes or so, I'm going to talk about the transferable learning that we've achieved from implementing and evaluating one of the first PrEP national programs across the world. I'll touch on the challenges we're facing in providing equity of access, really in the context of a very bold and ambitious aim to eliminate HIV transmission in Scotland. To give you a bit of background, there are about 5,600 people living with HIV in Scotland at the moment. Each year, there are 200 people who are newly diagnosed. About half of those are gay and bisexual men who have sex with men, 10% are people who inject drugs, and 30% are heterosexual, with 10% being a mixture of trans and transgender people, or their route of acquisition is unknown. A quarter of all newly diagnosed infections have been acquired in the last 6 to 9 months. Clinical care is excellent. As I mentioned, Scotland was the first country in the UK and one of the first in the world to implement a national PrEP programme, which it did almost exactly 4 years ago. Since then, about 4,500 people have been prescribed PrEP at least once. And PrEP is an two anti-HIV drugs which are given to people either on a daily basis or around the time of sex to prevent HIV acquisition if they have sex with somebody who's HIV positive with a detectable viral load, i.e. not on highly effective medication. Of the people who have taken PrEP, almost all of them are gay and bisexual men who have sex with men. However, we've got about 45 people who inject drugs on it, and I'll talk about them a little bit later because they're really important in the context of an outbreak of HIV in people who inject drugs, predominantly in Western Scotland, since about 2016. Half of people who take PrEP take it every day, and the remainder take it for several days around the time of sex. And overall, there have only been 4 instances where people who've been prescribed PrEP at any time have actually gone on to seroconvert or to acquire HIV. You can get PrEP through sexual health services, and pretty much that's the only place you can get it. PrEP is very much delivered as part of good sexual health. It's part of a healthy sex and healthy lifestyle in general, and delivered in the context of full sexual health services, prevention, vaccination, checkup testing, contraception. And we've got a national monitoring system which has been absolutely critical to giving us the data to allow us to evaluate how well we're doing as we've gone along. One of the most important studies that we did was to try and estimate the impact that PrEP has had on HIV at national population level. And in this study, which was published at the beginning of the year in AIDS, we looked at the impact of PrEP on new HIV diagnoses over the last few years, and also a retrospective case cohort study in which we compared gay and bisexual men who have sex with men in the 2 years before PrEP was introduced with diagnoses of HIV in that group in the 2 years since PrEP was introduced. It was really gratifying to see that over the time period of PrEP being introduced, new HIV diagnoses had dropped by about 1/5. And what was important is if you look at the group of men who have sex with men attending sexual health clinics, what we see is that there's actually been a drop of 75% risk of HIV in those people who'd been prescribed PrEP at least once. But interestingly, it also fell in men who have sex with men who had not been prescribed PrEP, but to a lesser degree, fell by about 1/3. It was gratifying to see that we were targeting and meeting the needs of the people at highest risk of HIV, because uptake was greater in those who'd had post-exposure prophylaxis, when you think you've been exposed to HIV and take drugs for a month to prevent an infection getting established, or people with previous STIs, which shows that they've had sex which has not been protected by condoms. A further study that we did was to actually ask ourselves the question of what are the characteristics of people still being diagnosed with HIV since we've got a PrEP programme in place. And in this study, we compared people diagnosed in the 2 years prior to PrEP with people newly diagnosed since the PrEP programme was established. And we were really asking ourselves, is the PrEP program that we've got, is it meeting people's needs? Is it reaching the right people? What we found was that there was a difference in characteristics of people who acquired HIV before PrEP as compared with people who acquired HIV since PrEP was widely available. What we found is that those who acquired HIV in the time of PrEP were less likely to be gay and bisexual men who have sex with men, less likely to have acquired their HIV in Scotland, and overall less likely to report their gender as male. What that was telling us was that the programme really suits gay and bisexual men who have sex with men and white Scottish individuals, but really the opportunities for this to prevent additional HIV infections, to get more traction in preventing transmission, are quite limited. And it made us think about how we would need to provide different services to reach more people to extend the benefits of PrEP more widely. And this meant looking particularly at the needs of women, people who inject drugs, and people from transgender and non-binary groups. And it can't just be all about PrEP. PrEP is not the only way to prevent HIV. We have to think about condoms, we have to think about behavioural changes, and we have to think about societal needs, reducing stigma, and really opening people's eyes to the benefits of PrEP and HIV prevention very much on a more wide, more normal basis. So thinking about people whose PrEP needs are not being met by our current model of PrEP through sexual health clinics. What's the evidence? What do we need to know? And what do we need to do going forwards? So we did some smaller studies, first of all, in a group of women of colour in Scotland and London, then in a group of people who inject drugs in Glasgow, where there's been an HIV outbreak since 2016. And then finally, drawing on some really nice work from one of the non-governmental organisations, Waverley Care, which is an HIV charity working closely with Scottish Trans. So turning first to the study on women, these were focus group studies where we asked women, some of whom did have HIV, some who didn't, some who'd never been tested, what they felt about PrEP, what they felt about HIV, and whether they thought PrEP was something for them. Our findings were really important, and this has helped us think about PrEP programs for people in this particular group. Really, what we found was that multi-layered influences, including interpersonal networking, are responsible for framing women of colour's feelings about safer sex, about HIV, about testing, and potentially about PrEP. That the PrEP campaigns, which have been so useful and helpful in engaging men who have sex with men, now need to really specifically address community norms for women of colour. Women-focused PrEP marketing is needed, and we need to think about delivering PrEP outside of sexual health clinics, where women of colour didn't always feel comfortable coming, didn't always feel comfortable discussing the really quite sensitive areas we need to establish people on PrEP safely. A similar study in a group of people who inject drugs was really important in helping us get the evidence needed to develop a new service. What we found, this was a couple of years ago, was that people who inject drugs knew very little about PrEP, but knew that they were at risk of HIV, and they thought that PrEP could really be of use to them. However, they would need PrEP to be provided in places that they usually went, by providers they trusted. This meant outreach services. And for it to be easy, explained at their level, and possibly involve peers who could really speak to their lived reality. As a result of this and other work from one of my colleagues, Professor Hutchinson and her team, we managed to develop a PrEP service for people who inject drugs, which we've shown to be feasible, but very costly because of the resources required to support people effectively through what can be daily medication for a number of years. And finally, looking at the NGO report on the needs of trans and transgender and non-binary people, what we see again is that we need to think about service models and provision of PrEP outside sexual health clinics, where some people have had very negative experiences. Clearly, you don't want to be going to a setting where you feel that people have judged you in the past, even if things have changed significantly since then. Again, the need for peer-led services in the community was voiced by many participants. So in terms of our successes and challenges, well, we've done really well with gay and bisexual men who have sex with men, but we now need to think beyond this group and look at the groups who we might need to provide different models of care to best suit their needs. Where do we go with people who inject drugs? We know we can do it, but it's hugely resource intensive. We know a little bit more about women's needs. So I think going forward, we need to think about how we can offer PrEP in settings and in ways outside of sexual health clinics that mean that women will come forward and be interested to take up PrEP. And the same again for people from trans, transgender and non-binary communities. Just before I finish, I want to touch on the Syndemics model of health. This is really urging us to switch from the understanding of diseases or infections as very distinct, separate entities, to see them as acting synergistically with a massive impact on the individual and on the wider community and population health. What that could mean in the context of prevention is that it's pointless me being very excited about my HIV prevention initiative, one of my colleagues being very interested about their hepatitis C prevention initiative, if really for the individual, the most important thing in their life is a roof over their head, prevention of harm from domestic abuse or street violence. So it's thinking about the person very holistically in terms of their needs and really working with others a lot, and I think almost inevitably outside the healthcare sector, to think about that individual addressing their needs in the hierarchy that's important to them, not necessarily the hierarchy that's important to us. So really just to conclude, we've shown that combination prevention is key and it needs to be tailored to different groups. And for some, it's going to be far greater than just HIV. And if we continue to focus on a very narrow area of interest for an individual, we're not going to get traction. But thinking bigger is going to be difficult. We're going to need to break down barriers and work outside of our silos. We only know what we know now to frame how we go forwards because of very rigorous evaluation. It's not enough to implement to say that the people coming like it, therefore it must continue. We need to use the science and the evidence wherever possible. And this has been phenomenally important for us in Scotland, where we are in many respects leading the world in the sort of research we've been doing and how we've evaluated it. So many people have been involved in the work I've presented. You may well be hearing from other professors at GCU, Professor Goldberg, Steedman and Hutchinson, and we all work together in infectious diseases, particularly bloodborne viruses. Again, community groups are absolutely essential to our work, and I want to thank them and particularly our colleagues from around the UK who've helped us very much get to where we're up to in Scotland. Thank you.